afternoon, everyone. Thank you for joining us today. I'm Jody Hubler, and I am Vice Chair of the Medical Alley Association and your host for the first part of our session today. Before we begin, I will remind you that the chat function is active and being monitored. Please feel free to use the chat function today during both of our sessions. We have a fireside chat. I have the privilege of moderating that portion, followed up by a panel moderated by Alexis. You will want to be here for both sessions, and we are extremely excited about our participants, the opportunity, and this important topic. Before we begin, let me first welcome Stacy and Tim. Stacy Stewart is president and CEO of the March of Dimes, just the 5th president of the organization founded in 1938. In this role, Stacy heads the organization leading the fight for the health of all moms and babies. She is responsible for all aspects of the organization, including strategy, vision, and operations. Welcome, Stacy. Also joining us today is Tim Spilker. Tim is the CEO of United Healthcare Community and State, proudly serving nearly 6 million Medicaid members, including more than 2.7 children in 31 states, plus Washington, D.C. Tim, welcome. Thank you for joining us today. Stacy, before we begin in the now topics, we have to ground ourselves in a bit of the how we got here. Could you please level set for us and give the context for both the historical and the systemic context for the maternal disparities that we experience in the United States?
Sure, and Jody, thank you for being here, and it's great to be with Tim as well, our great partner at United Healthcare. You know, this is really something I think is very interesting, and I think it's really fascinating when you look at where we are today with respect to maternal and infant health disparities. I think a lot of us engaged in this conversation are sort of shocked to really understand that, you know, for example, Black women die at a rate of 3 to 4 times that of white women in this country, that Black babies are still dying at twice the rate of white babies before their first birthday. We talk about these statistics as if they are just present day and issues that, you know, we're dealing with today. And I think we lose sight of the fact, or maybe we don't even remember or understand or have never learned, that really there's never been any point in time in this country when Black people, the people that look like me, that are the descendants of the formerly enslaved people of this country, that there's never been any one point in time when we have had access to high quality, affordable healthcare in this country. It's never existed. You know, if you think about the history of this country, slavery starting around 1619, ending around 1865 mostly, Jim Crow era for another 100 years. I was born in 1964, the same year as the Civil Rights Act was passed. And we still don't have universal health care in this country. And we still have millions of women who live, both women of color and white women too, but disproportionately women of color, who live without even the basic ability to have health care coverage, to go see a doctor affordably. And so in realizing that, we should not be really shocked that we see the disparities that we see today. Of course, that's just talking about healthcare access. That's not even talking about the other systemic failures in our society that make it more challenging for people of color to live a high quality of life. Lack of decent housing, living in food deserts, lack of access to equity in pay and things like that. So here we are today, it's 2021. We're in the midst of a global pandemic. We've been talking a lot about the disparities that exist and that we've seen now really laid bare as a result of the pandemic. But we have to be really clear, this issue around maternal and infant health and this crisis we've been seeing has been here for all of our lives. Whoever's on this call, it's been around for as long as any of us have been living and before that. And we have to actually, and now it's only been made worse because of this pandemic. So it's really important to understand that the very basic founding of this country was always, you know, we're built on a foundation where many people of color, especially those formerly of the descendants of formerly enslaved, indigenous populations and others have been left without the basic opportunity for high quality care as compared to others in this country. And that is why we have the disparities we have today, where 2 women die every day due to pregnancy and childbirth complications. 2 babies die every hour. Disproportionately, people of color are experiencing these outcomes. And that's really the foundation of it. And a lot of it does lie in the very systemic racism that this country has really been founded upon.
Thank you. And thank you, Stacey, for grounding us. I think you're right that we do see that people don't have that sense of context or history. They view it as a now and emergent issue, and without understanding the systemic nature and the full context, we only really engage in surface change. And I know as you and Tim and I have been preparing, we really actually want to, no, we only have a limited amount of time. We really want to jump into what's going to really drive some sustained change, not just surface actions here as well. So Tim, let's bring you into this as well. Clearly, United Healthcare is the second largest healthcare company in the United States. You're the largest health insurance company in America, listed as a Fortune 7 among the Fortune 50. You bring a unique perspective to this discussion as well. And a 44-year-old company since United's founding. Can you give us some additional context to build upon Stacey's for the how we got here from your perspective, from an insurer's perspective?
Yeah, and I think Stacey really did a nice job of summing up, I think, the problem, and we see the same issue. We kind of think about it at the individual level first, and just in the work that we do with our members. What we know is that many of our members are working. Many of our Black moms might be working a couple of jobs. They don't have the luxury of many of us do to be able to take time off of work, to be able to get to the doctor, to get the prenatal care that they need. Or there could be a Black mom who's currently engaged in the healthcare system, who is working with a hospital staff that doesn't reflect her, doesn't look like her, doesn't understand the needs that she has, and might be questioning the support that she gets. Or you may have a doctor's office that wants to do the right thing and sees some of these systemic issues underway, and they just don't know what to do. So we see all of that. We work both at the individual level with individual members through care management programs, but then, as you mentioned, we're also operating at scale. So we work across the country and in many markets. And maybe the place to start is really with Medicaid. This is a really significant program in the U.S. I think folks often don't understand the impact and the scale that Medicaid program has across the U.S. It's a program that serves around 72 million folks in the U.S. It's about 1 in 5 of all Americans. It's almost 20% of all healthcare expenditures. And then most importantly, it serves around 40% of all children, about 83% of all kids who are under poverty, and then covers about half of all births within the U.S. So for UHC, within our Medicaid programs, we're providing support for around 130,000 births every year. And so companies like us, we see the structural components. We spend a lot of time thinking about how healthcare is delivered and thinking about our role. We see data. We work with providers directly, we work with communities, and we see all of these gaps in the system, these really complex kind of healthcare system delivery issues that then build on all of the historic and structural racism that Stacey is talking about, but then are really applied in individual lives. And so we can talk a lot about what we're trying to do in terms of the programs that we have, but we see those same problems just in terms of both structure, in terms of policies, in terms of organizations, and then most importantly at the individual level.
Thank you. So with that context and the time that we have, I think one of the pieces that brought us here together is the recent announcement of the partnership between the two organizations, and that cross-industry collaboration is something that we all know, particularly here in our ecosystem and then also nationally, is one of the imperatives to driving that systemic and also then sustained change. So Stacey, the March of Dimes has leveraged partnerships significantly across 80 plus years that the organization has been in existence. So can you help us, what's unique about this recent funding from United? And it was of note to me in some of the preparation that the statement between the two of you also then focused on hospitals with severe maternal morbidity and mortality. So it was interesting to bring the partnership of the two of you, yet focused on the hospital system. So give us a little bit of insight into the partnership and the opportunity.
Yeah, no, it's really great. And I can't tell you how grateful we are and so excited to be working with United Healthcare on this amazing partnership that really got started through the leadership of HHS in the prior administration, continuing into the new administration. Because I think everyone is now, and it's really interesting how the issue of maternal infant health is looking more bipartisan than ever before, right? We've seen folks on both sides of the aisle come together and say, we find this unacceptable, as we should. That the US ranks as one of the most dangerous developed nations in the world in which to give birth. That is not a statistic, that's not a status that we should be proud of. And I think everyone across the board sees that. So what HHS did was to say, what can we do to take a hard look and provide leadership in addressing this maternal health crisis in this country? They asked us at the March 9 to be involved in helping to lead a cross-sector approach with multiple partners, multiple stakeholders involved, with Black women and Black women advocacy groups and healthcare groups really helping to lead the charge with us. And United really stepped up to help provide incredible support to get this launched with a very sizable investment of almost $3 million to get us launched in this way. This is really an effort to address a few things. One is, how can we reduce maternal deaths in this country, maternal mortality and morbidity? Because remember, 700 to 900 women die every year due to pregnancy and childbirth complications. Doesn't sound like too big of a number, but it actually is a pretty bad number considering how wealthy of a country we are. But the really important issue is that almost 50,000 women every single year come close to death. That's the maternal morbidity number. So we've got to look at both of those things. And also looking at some issues around things that really increase the risk of mortality and morbidity. For example, low risk C-sections, which we see as really a manageable outcome for some women that could reduce the risk and could make sure that they don't become severely ill or even create a situation in which they may die as a result of pregnancy and childbirth, reducing those low risk C-sections. Looking at ways to manage hypertension, which, heart-related diseases are a big reason why so many women end up having challenges during pregnancy and even after pregnancy. So this partnership is really trying to use data and evidence to look at care, especially within hospitals, to try to intervene with those hospitals where we see disparities, where we see even within a hospital, there are big gaps between maternal mortality and morbidity rates between Black women and white women, or across hospitals. We know that there are certain hospitals that have big challenges compared to others. We know that there are big parts of this country, like for example, in the South, where we see higher rates of maternal mortality and morbidity. So this is really just at the beginning stages of a fantastic partnership. It's going to start with a pilot of a couple dozen hospitals, expand about 100 hospitals over time. But we hope that in the matter of a few years, we can see substantial decreases in the level of maternal mortality and morbidity rates in this country, especially affecting Black and brown women, where the issues are disproportionately occurring.
Yeah, I can actually hear the hope and sense of excitement about the potential in this in your voice, Stacey. Tim, from a United Healthcare perspective, you are clearly uniquely positioned, as you've highlighted previously. So from your perspective, what are some of the tangible outcomes that you're seeking in your work with March of Dimes? And particularly, Stacey's laid out some of the larger objectives around morbidity and death, but you also have some opportunities really digging into that clinical practice, which is just, again, another level of real deep change. So what does that look like? And what are some examples of how you're uniquely positioned to be the partner in this?
Yeah. Well, you're right. I think this is really deep. And I would say that for us, what we're excited about is that working with our partners and with a broad-based coalition that we've established, the goal really is to get into actual practice change within the hospitals and the way that hospitals actually deliver care. And for those of you who are providers, and I am not a provider nor am I a clinician, so forgive me on the front end of this, but it's really, really hard to actually change how care is delivered in terms of practice patterns and the operations and the procedures and so on. And so what this is really designed to do is to bring experts together, as well as the voice of the individuals that we actually serve, to really ensure that we've got evidence and training and support at the hospital practice level, at the individual physician and nurse level, to then help assess, how specific care is delivered in the practice setting, to create essentially like a quality improvement plan of sorts at the practice level. So assessing things like training and checklists. One of the key areas is hemorrhage. We know that that's an issue. So how do we help train doctors and nurses to be more, have the experience and the information that they need to be able to identify issues before they happen, and then have things like safety cards, very simple things that we can do in a practice setting that actually improve health outcomes. So the goal is to work with all of our experts to then develop toolkits and trainings, essentially bundle all of this support together to then implement this and test these practice changes in these hospitals, and then work with the data that we have, the data that HHS and others has, to then evaluate the outcomes and then do kind of a process of continuous improvement. So we're really excited about this, and yes, while United has a lot of resources and capabilities, this is one of those areas that we absolutely cannot do on our own. We really depend on the partnership of a broad coalition to bring the expertise, to bring the evidence to the table. Where we can help then is with the relationships with providers, with incentives, with care management, with other programs around individuals. But this really is kind of a broad coalition, and that's really one of the reasons that we hope that it will be successful.
Great. We actually had a question come in that fits right at this inflection point, Stacy and Tim, ahead of the session, that asked, what role do you see for community-based nonprofit organizations who often provide health services to at-risk communities? For example, many nonprofits tend to be an extension of the formal health system and can function as spokes in a hub and spoke model. So whichever of you would like to answer, curious about the role of community and potentially community nonprofits as a hub and spoke to some of the efforts that you're undertaking.
Well, I'll start there. I think it's hugely important, and we work with a lot of community-based nonprofits to try to integrate more of our approaches with organizations that really are in touch with communities and neighborhoods and women who really are mostly in need of the support. I think one of the things that we've got to think about is that, when you look at the issues of maternal mortality and morbidity, it's not about a third of the deaths happen right at the time of childbirth. About a third of them happen 1 week after childbirth, out 1 year past the date of birth of the child, and then 1/3 happen during pregnancy. So this idea of the life course and supporting women before they're pregnant, during pregnancy, at the time of childbirth, and even postpartum really requires a big lift. We will be putting too much of the onus of this issue on institutions to fix if that's the only place we're looking. We have to have a very integrated, comprehensive approach that involves community workers, community health workers, state and local governments, and a whole range of others, from the private sector, the public sector, the nonprofit sector, to address this issue. The last thing I want to say about this is that one of the things that we are focusing on at the March of Dimes is how do we take, for example, our partnership with HHS and United Healthcare and complement that with other kinds of more systemic policy changes that really will give support to many of these nonprofits, to many of these community workers. How can we look at really investing in a perinatal workforce, to invest in the number of doulas and midwives who can provide culturally competent and congruent care? How can we invest in those community health workers and nonprofits who are in touch with women, who are often the trusted providers of care to many of these women, to work in a complementary fashion with healthcare providers and others? The Momnibus Act, for example, is a set of legislative bills that will address a lot of these issues, and a range of them. And those are some of the things at a policy level we'd like to support, and we do support the March of Dimes, because there's no one silver bullet solution to this. This really is a very comprehensive set of actions that we need to take over time, and we need to be inclusive of all the parties who are trusted and relied upon in communities, especially in those communities that have been marginalized and disproportionately impacted.
Okay. Tim, anything you'd like to add? Otherwise,
Yeah, maybe the only thing I would add, I totally agree. There's no silver bullet on any of this. It's really, really hard work. But one of the things that I think we've learned is that actually we've been able to use a lot of our health risk assessment data and enhance that to assess for gaps around social determinants. So all of the factors that happen outside of the healthcare delivery system, which really do account for about 80% of individual health. So food, transportation, housing, so on and so forth. And one of the opportunities that we see is to leverage that data to identify not only individual needs, but community needs. And then, as Stacy said, work together with communities to identify where there's gaps, make capacity investments in communities, but do all of this in conjunction and in partnership with communities. I think one of the key lessons we've learned over the years is that this has to be a community partnership, and each community is so very different that the solution may look different in each community, and that we really need to partner with the community in developing those solutions. And so we're excited about that. We think this is a start to kind of integrating and thinking in terms of systems-wide change, but doing so at the community level. And that, of course, you need nonprofits and community organizations to support that as well.
Yeah, thank you, Tim. Stacy, I know that at some level, this is only the beginning. You've made that clear even just in your comments here, and in preparing, read a lot about you talking through the complex needs, that this isn't just a clinical component. You just even spoke about at time of pregnancy, post-pregnancy, and that we're starting to read more and more about that community activation, social determinants of health, a number of aspects that people keep it at a high level, but you're really looking to drive some additional initiatives through March of Dimes in 2021 that are going to not only address the clinical componentries that we've identified in this partnership. Would you highlight some of those additional initiatives and changes that we're going to see from your organization in 2021?
Absolutely. Well, I mentioned some of our advocacy work, which is really, really important at a federal level and a state level, and it's a pretty significant amount of work that we focus on at the March of Dimes. But another aspect of what we do as well is we invest a lot in professional education and training for healthcare providers. And one of the areas that we have launched that has just done exceptionally well, I think, is that we launched implicit bias training for healthcare providers, because we did recognize that, too many women of color, Black women and others, expressed that they experienced that they were not feeling heard and respected by their healthcare provider or their institution. In fact, there's some research that shows about 20% of Black women have said that they've actually experienced overt racism in their interactions with healthcare providers during their pregnancy and childbirthing process. So one of the things that we have instituted is an implicit bias training for healthcare providers. We've actually had, I think, over 10,000 healthcare providers be a part of this. It's been a virtual training, which has actually been terrific during the pandemic, that we built it to be a virtual training, but it is built to be a group training session. But also it sort of walks through the history of how we got to this that I sort of previewed a little bit earlier. Talks about how people can individually identify when they have their own implicit biases. The whole point of this is to say, if you're not aware of some implicit or unconscious bias that you might have, but if we have it, and if it to any extent interferes with our ability to provide the highest quality care to any woman, then it is our duty as healthcare providers to recognize that, and then to take the proper steps to try to ensure that that bias does not interfere with that delivery of the highest quality care. Because at the end of the day, no woman should be left without feeling heard, respected, and having her needs met. I mean, one of the things that we know is of all the maternal deaths in the country, even CDC has said 60% or more of the deaths could be prevented if women were properly diagnosed, if there were not delayed diagnoses, if women were actually responded to what kind of care they need at the time they need it. Some of that, to the extent that implicit bias is a part of that, is what we're trying to sort of root out so that we can all serve women, especially women of color, in a more effective way and actually see a positive impact on health outcomes at the end of the day.
Thank you, Stacy. Tim, before I go to a question from the chat, I want to, Stacy mentioned also activities that are really focused on bipartisanship, that we're seeing this across the aisles finally starting to get focus and attention. The Maternal Health Action Plan, the President's American Rescue Plan, each of these had very significant focus on efforts, not only on reimbursement, continuation of benefits, acknowledging pre, post pregnancy, and mom and baby included. Are there, one, what do you make of these recent efforts and actions that gives you hope for really driving change? And then do you see some additional efforts coming forward in 21?
Yeah, I mean, we've been obviously watching all of the policy changes, I think, very closely. You know, clearly the administration is very focused on access. You know, the postpartum coverage and the availability of funding to states for that is for sure one really important venue for that, and we're excited about that because, as Stacy mentioned, there's a lot that we can do postpartum to make sure that we're helping to support moms and communities. I think we're seeing a lot around just access overall, so incentives to continue to expand Medicaid, which we know that in expansion states, individuals have received just much higher rates of coverage and so on, which is obviously important. And then other smaller things like home and community-based funding. So there's additional dollars available for those. So I think we're excited about those. I think that anything that we can do to increase access and increase coverage to high quality care is important. The other thing though that I think is important, and we've seen this even just in the selection of administration officials, is a tremendous focus on health equity and reducing disparities. And so even things in terms of the vaccine and COVID response, providing additional funding for FQHCs and safety net clinics, both for testing as well as vaccine access. These are really important, under the radar almost type of activities that just really support underserved communities. So we're excited about all that. We believe that's going to continue to support the safety net system, which is just really important.
Thank you. Stacy, we'll tee up a combo for the last question, knowing that we're going to run up against time for our panelists. One of the areas that you talked about in this cross collaboration is also one of education. So it's two-part. We've had two questions come in that I'm going to actually combine. One is, what do you see for education and helping to achieve the goals? And then combined with that is an opportunity to educate right now, because I actually know from you the answer to this question. In that, regarding disparities that are seen in the mortality and morbidity, is it more based on income level versus race? And is there any difference when it comes to the implication of Black, Brown babies and women? So education, and then also is it a race and income level?
Yeah. So let me start with the race and income one, and I'll go to the education one. So it's a very good question. I think there's no doubt in this country, people are very disadvantaged if they happen to live in poverty. And especially with women who are, who are pregnant and are delivering their babies. For all women, Tim mentioned the statistic around how many births are covered by Medicaid. It's a shocking number. I think I've asked people this number to think about the fact that over 40% of all births are, covered by Medicaid is really much higher than what most people would sort of believe. That just tells you how critical it is and how many families in this country are desperately in need of help just to make sure that they can live, a decent quality of life. The fact that in this country we have many women who are dropped from Medicaid 60 days postpartum is why that change that Tim mentioned is so important, giving the states the option to extend Medicaid postpartum 1 year Because if a woman who is low income, who's relying on Medicaid to deliver a baby, has chronic health conditions, it gets dropped from her coverage 60 days postpartum, but still has continuing issues from preeclampsia she might have experienced, or continuing issues with hypertension or diabetes, there's no way we should be dropping women who need follow-up care 60 days after the baby is born. So there's no question we have an issue around income and reach, and that's in rural areas as well as as urban areas. But here's what I would say. Research has also shown that a high income woman of color, Black woman, with access to education and income is still 5 times more likely to die as a result of pregnancy and childbirth than her white counterpart, than another white woman who has a similar level of income and education based on research. So we cannot just say that this is an income problem. It is not. And that's really important to understand. We have something deeper and darker and more systemic that's going on in this country that has more that is also a component of race and racism attached to it. And that's really important to understand. The other part about education, and Jody, I don't know if the questions around education of providers, education of people generally, or education of women who are pregnant. But one of the things that you and I spoke a little bit about education when we prepped for this. Let me go to just 2 quick things because I know we want to end this pretty soon. Yeah. We have to be better educated in this country generally about why we got to this point, which is why I started my remarks with just a little history lesson. And I'm not a historian. I am not a professor, but I am someone who tries to understand our work at the March Times in the context of where we have been in this country and where we need to go. It's really important for us to understand we didn't just end up here yesterday. This has been an issue that's been developing over time. And so being educated on understanding that is helpful so we understand how to get out of this, right? And acknowledging the past so we can build a better future is really important. It's also really important that women become better educated about how to manage their own health, speaking of education, so that women can be better advocates for their own health as well. And they understand what kind of treatment they should deserve and how they advocate for themselves in the context of the clinical setting and beyond. And so those are some things that the March Times we're really trying to hone in on for sure.
Stacey, you could be a professor if you wanted to be.
Maybe in my next life.
You've given education to all of us, so thank you. Tim, thank you for your participation in this important conversation and working with Stacey to also set up our entire discussion for today. We are grateful to both of you and your time. Alexis, we'll have you come on, and I know we've got an amazing panel coming up next. Thank you both. Thank you, Stacey. Thank you, Tim. Alexis, I'll turn it over to you.
And thanks, Tim.
Thank you.
Perfect. Hi, everyone. Good afternoon. And thank you, Jody, for moderating a wonderful fireside chat that we all saw between Stacey Stewart, President and CEO of March of Dimes, and Tim Spilker, CEO of United Healthcare Community and State. So everyone, my name is Alexis Kohansky, and I'm the Director of Member Engagement here at Medical Alley Association. And I'm here to moderate this next portion of the webinar, and it has an impeccable group of leaders on this issue. So as we were just privy to, the fireside chat provided us with enlightening perspective. It highlighted the importance of strategic partnerships and opportunities that they bring. In this portion of the webinar, we're going to dive a bit deeper with our panelists. And more specifically, what role does technological innovation and partnerships play in solving this crucial issue at large? So when we think of how we're going to frame up this discussion, we're going to begin with the introductions of each of our panelists, and they're going to share what unique insight each of them bring to this issue. Then we're going to dive a little bit into their perspectives on the disparities and why healthcare hasn't done enough to solve them. We will transition into the role that technology and innovation plays in solving this crucial issue. And then end with a discussion around the strategic partnerships, why they're important, and each individual panelist's call to action on how we can move forward. So without further ado, we're going to start with our introductions. And Veronica, I would like to start with you.
Thanks, Alexis. Hi, everybody. This is Veronica Adamson. And I'm just so glad to be here to talk with everybody about this important topic. I myself am a twice high-risk mom, and actually that's what drove me to be in the role that I'm in today, which is leading Philips' global obstetrics monitoring business. We're the leader of obstetrics monitoring devices and software globally, and our mission is really to work with an ecosystem, so echoing what was just shared, to transform high-risk pregnancy and enable clinicians to meet moms where they're at. So for us, it's, you know, both as the obstetrics business, but also as a large company in North America, we're very active both from the technology perspective, but also in supporting this from a legislative perspective. So very excited to be here today and to share with all of the great minds on this call.
Fantastic. Thank you so much, Veronica. We're going to move over to Dr. Saul. Can you please introduce yourself?
Thanks, Alexis, and thanks for having me today. My name is Lisa Saul. I am a perinatologist, a high-risk obstetrician with Allina Health, and I lead the Mother-Baby Clinical Service Line for Allina Health and Children's Minnesota. In that role, I have responsibility for all of the programs and services related to maternity care, both inpatient and outpatient, and have responsibility for our quality outcomes. So the quality metrics that we've been talking about and heard about already in our fireside chat, that's me bringing that to the bedside for our organization. So I'm really proud to be here today representing the Mother-Baby Clinical Service Line, and thank you for the opportunity to be a part of this panel.
Fantastic. Anne, we're going to move on to you.
Hi, I'm Ann Holder. I'm the CEO and founder of Morani Health, which is a company that was founded in partnership with the Mayo Clinic and Mayo Clinic Ventures. And we are focused on developing technology to improve maternal and fetal outcomes for use in the home, hospitals, and clinics. And quite honestly, this was a journey that I personally embarked on, just because for me, with a background in medical technology, I didn't understand what was really needed, and I didn't understand what was happening, particularly in this country with outcomes. And so my passion is really to bring new technology to help deal with some of the issues that we're talking about. So thanks for having me. Glad to be here.
Thank you, Anne. We are excited to have you here as well. Dr. Sylvester, can you please introduce yourself?
Thank you, Alexis, and good afternoon, everyone. Thank you so much for the invitation. It is an honor to be part of this distinguished panel. My name is Shirley Sylvester, and I'm currently a Senior Medical Director for Women's Health within Johnson & Johnson. I'm a family medicine physician with background experience in maternal health from a public health perspective. I have a lot of passion for empowering women, and that also includes giving everyone, regardless of race or socioeconomic status, the opportunity to have the birth experience that they deserve. I really look forward to hearing what all of you are going to be presenting today, and also to share my experiences with you. Thank you.
Fantastic. So we're going to transition into our first topic. So we're going to start with Dr. Saul. So this initial question is for you. What are the factors from your perspective that exacerbate maternal health disparities for women of color in the United States? What makes this issue so challenging to solve? And why hasn't healthcare done enough to solve this?
Off mute. Thank you. Well, we've heard a lot about some of these issues already, and I'll bring it to the clinical level. As I said, that is the majority of what I do. And start by saying that I think that women's health in general has not been a top priority in the United States. And so if we then parse it down further to women of color, and their experiences and outcomes in the maternal morbidity and mortality space, it's not really a surprise that we haven't seen quite as much movement forward as we would expect to, knowing that our outcomes are not on par with many other developed nations around the world. And I think that sometimes the conversation does get stuck on the race term in terms of, Black women, women of Native American descent, Latinas, et cetera, having disparate outcomes. And really the issue that was alluded to earlier is racism. And that's why we are seeing these disparate outcomes. There's nothing different about the color of my skin that would cause me to have morbidity or mortality in my pregnancies or in my birth experiences. But it is more of the experience that women have over the course of their lives just living in the United States that does create a toxic environment and does create a disadvantage in terms of health and health outcomes that do then play out in a pregnancy. And so we need to be able to acknowledge that that's the case, that there's a term for it that's weathering. And there have been many, many scientific articles about that, just acknowledging the differences, even for women that immigrate to this country, and the generational differences in their birth outcomes between those who are new to this country and have lived here over generations. So there's something to that in terms of the lived experience for people here. And then you couple that with the unconscious bias that we talked about earlier, racism, and how that plays out at the bedside. You've got a woman with a lived experience who is already going to be impacted in terms of her health and her health outcomes. And she's walking into a scenario where those that are charged with caring for her have certain biases against her and her child that impact that inability to be seen. Seen as a woman who needs that care, heard, listened to, and respected. And it's not a big surprise as to why we find ourselves in this particular situation. There are patients that I hear from all the time that enter into their pregnancy and childbirth experience legitimately afraid of death, and they are scared to have a baby because they're not certain that those that are taking care of them are going to listen to them if they have a concern, see them as a woman that needs that care and support. And respect them and their choices and their partner's choices and their family's choices. And so we have a lot of background baseline work to do in addition to how we get to solving these problems. One is addressing those biases and those opinions and issues that people have with anyone that looks different than who they are or who is different than who they are. But we also heard a lot about really getting regimented around clinical protocols. Patients come to us expecting that we know what we're doing and that we're offering them the highest quality care that is available. And we have to be able to be more standardized in the way that we approach things like hemorrhage, the way that we approach things like hypertension, the way that we approach infection and our response to that, and timely response to those sorts of things that cause significant morbidity, and not usually mortality, but it does happen, as we also heard about. But these are things that cause significant harm to our patients, and we need to get better and more disciplined about that in healthcare in general. And I think that why we haven't done enough about this already to solve this has to do with the coordination. There's no one rule book. There's no one recipe for how we take care of people, pregnant people in our country. And so it becomes quite common to enter into a situation where we see more near misses that aren't formally documented and accounted for one. I think that our quality outcomes and the way that they're reported are also pretty generic, and they don't dig into mandated reporting around race, ethnicity, and language that I think would be very revelatory if we were to look at that. I think that It's easy to say that you're meeting the mark in a certain quality outcome, but if you really were to dive down a little more deeply into who are you meeting the mark for, it would be very telling. These disparities that we speak of would be quite a bit more telling, and also should be mandated. So I think that there's several different factors at play here as to why we're where we are, what we could be doing about it, and why it hasn't come as far as it has, or that it could be.
Dr. Saul, thank you for that perspective. I think, known about this issue, of course, but the most striking point to me in that fireside chat is when she shared, once you control for education and income, a Black woman is still 5 times more likely to have an adverse effect from delivering a child as her white counterpart, which I think is extremely striking. So I appreciate your perspective in terms of from the hospital setting. I want to transition over to Dr. Sylvester and have her share her perspective on these questions.
Yeah, no, thank you so much, Alexis. And indeed, as I reflect about the panel that or the fireside chat, I also think a lot about, institutionalized and structural racism and the important implications that these two things actually have in the mortality crisis that we live today, where, as everybody has stated, Black women have 3 to 4 times more likelihood to die from pregnancy-related causes. So it is a big issue, and it's an issue that is not something new. I mean, there has been research on this, that poor maternal outcomes among Black mothers cannot be only attributed to one cause, not only about social, about poverty or about educational attainment or even access to care. And that structural racism actually is a powerful social determinant of maternal health. And it has roots in historical systems of oppression, of the way that we have devalued women of color in subtle and sometimes not subtle ways, in the way we implement healthcare policies and practices across the country. And Dr. Saul alluded to the weathering hypothesis. I would like to add a little bit more on that, because when you account for all the other factors, you cannot really tell what is what. And what the weathering hypothesis really states is that African American women deteriorate in early adulthood close to pregnancy as a physical consequence of that cumulative socioeconomic disadvantage and that chronic stress that they receive from historic oppression. And so when we compare these outcomes across races, we realize that the outcomes in Black women are poor regardless of that socioeconomic status, which that is why I'm saying that it could potentially be explained by the racism. And other research actually has suggested that racism compromises health, and that it is indeed contributing to the high maternal mortality that we see today. And I'd like to end also by mentioning that, obviously the factors that surround the maternal health mortality are complex. There are obviously other social factors that are at play, about the environment where that woman lives, her age, and a lot of social aspects that are going to really affect her quality of life overall. And if we take some examples, for example, prenatal care, we all know that prenatal care is important for improving maternal health outcomes and infant outcomes, yet we see a vast racial ethnic disparity in how women are entering into prenatal care in the US. And that is something, it's a proven intervention, but yet we see these disparities. And I can go on and on and on about different disease conditions, gestational diabetes, domestic violence, a lot of other conditions where, women are at disadvantage from a racial perspective. So overall, this intersection between the social determinants of health and birth outcomes have contributed to this pervasive racial ethnic disparity in maternal health and maternal health care. And this actually has perpetuated these complex factors that are putting women of color at a disadvantage. And what we see is that there have been many clinical approaches that have tried to solve the problem, but overall, really, a solely clinical approach is not going to solve it. There's not one clinical bulletproof here. So we have to take into consideration not only the clinical perspective, but all these other social determinants that are going to be important in really understanding the root cause and solving the root cause of the issue. Thank you.
Thank you. And there's so many great things that you shared there. And I want to have Veronica, I want to have you weigh in on this as well before we transition into the next topic.
Yeah, well, first off, I absolutely agree with everything that Dr. Saul and Dr. Sylvester have shared here. I mean, I think that those are really the key points. And I think, you know, one of the things that we see a lot in the prenatal monitoring space is that, you know, women of color, as was just mentioned, are disproportionately need to manage high-risk pregnancies, right? Which implies a very large number of prenatal visits. And, you know, for something just like a fetal non-stress test, which is one of the tests that's done, you know, often for high-risk moms, you may be asking a mom who's got kids at home, who needs to take public transportation to come in for care, you know, let's say 20 times, which means taking time off work, paying for a babysitter, paying for gas. And sometimes, you know, they may live 2 hours away from their provider. So all of that in a context when they already don't really feel heard and don't completely trust the system, I think that that is, you know, one of the barriers, I think, to creating access for care, and that leads to the outcomes that were described. I think the other thing, and this was mentioned, I think by Dr. Saul earlier as well, is there's been so much focus on investment for healthcare, broadly speaking, but very little for women's health. So there are technologies, right, that could enable us to, you know, find things earlier, especially in this population, but they haven't necessarily yet been focused on or developed. So I know that's not exactly the question here, but I think that you know, is also one of the areas where that's creating some of the healthcare disparities.
Veronica, thank you. That's actually a great segue and transition into the next portion that we're going to chat about. So we're going to move this discussion on to talk a bit more about this issue as it pertains to innovation and technology. So, for example, Morani Health, previously Odonata Health, utilizes artificial intelligence and machine learning powered technology to support a health provider's management of their patients in all healthcare settings. So, Anne, this one's for you. What role can medical technology play in solving maternal health disparities, and what can be modified in healthcare settings to improve outcomes?
So yeah, I will address that. I believe there's two areas that technology can really affect change here. And the first one goes back to exactly what Dr. Saul and Veronica were just saying. It's advancements in technology, you know, and that takes money, it takes investment, and it's been lacking for quite some time in women's health in general, but in this area, pretty astoundingly so. So that's one area, but it's happening. It is happening, and we're making some progress. As well as another thing that I think can really help is the progression of the care setting from the hospitals and clinics to include prenatal and postpartum care in the home. And how do we do that, you know, in the home and develop that technology so that we can do that, so that we can actually capture things that are happening that could be going wrong. Again, good news that there's a lot happening with technology as more awareness is being brought to this. I mean, this panel alone is bringing so much attention to this problem. The government is looking at it. So we know it's an issue, we're focusing on it. I think we really are in a perfect storm right now, where prenatal and postpartum market needs, because of the awareness, are actually driving the technology. It's definitely evolving across healthcare right now. So if you look at what's happening with telehealth across other service lines outside of OBGYN, there's been a lot of inroads. And if anything positive has come out of COVID, it's really the acceptance of telehealth and utilizing technology in the home. And I think that's really what is going to catapult us to the next level in caring for these patients that are really not getting the care that they need. So if I do think if we can get into using technology in the home for prenatal care, it can be hugely beneficial for women, particularly women in rural areas that have so far to drive. Women who have difficulties getting to appointments because of their jobs, they don't have the transportations, it's just a logistical nightmare. And so they just don't get the prenatal care. And I do think that technology can help us overcome some of these barriers and really help keep us better connected to these patients that are at pretty significant risk. So, you know, if I look at the technology side, though, I do think that there is an incredible wave of advancement in medical technology, and it's really in the areas of biosensors, and then also utilizing AI, excuse me, AI and sorry, I need some water, utilizing AI and machine learning just to give clinicians a little bit more data that it's actually useful. And I'm not saying just data, but give clinicians information. And information that can be acted on. And if you look at some of the biosensors that are being developed now, they're non-invasive, they're easy to use, they're connected, they adhere to the skin, you know, they're on a device that can capture data, and it's data that is the fetal heart rate, the maternal heart rate, it's contractions, it's blood pressure. We've got the ability to transmit glucose levels. There's just so much that we can do in the home. But what I get most excited about is the actual advancement in AI and machine learning. We have so much data. And is that data right now truly giving us information? I would say it's not. But if we can take that data and utilize that data with outcomes and utilize machine learning so that you can see patterns in data and you can see things that are going wrong, and you can actually look at these patterns and give clinicians some type of an alert that, you know, something is going wrong, and actually see something that they might be doing this at home. The future might be doing a non-stress test at home, or just doing a health check at home, just to see what is going on and how that data can be acted on, and how do you address it right away so that we can really keep patients and their unborn babies out of dangerous situations. So I look at this whole data piece of it, and I think that is really what is so exciting as we move forward. And, you know, just that the data lakes that we have and these outcomes, and figuring out how do we utilize that and how do we incorporate that in our technology and do this in an environment in the home, but also in labor and delivery, and, you know, in the clinics as well. I think it goes across that whole continuum of care. And let's not forget about postpartum care, because postpartum care is it's so critical right now, and we're learning more, and we've got to start taking better care of the, these women and children after the birth, you know, and going out 6 to 12 months.
Thank you, Anne. One of the things that stuck out to me in what you just shared was the concept of not just data for the sake of data, but useful data, and the importance of that, and how we think about maximizing technology and ensuring that the innovation is being used to roll the ball forward. Veronica, I'd be curious to hear from you, from Philip's perspective, some ideas around innovative technologies and what role they play in this issue.
Yeah, absolutely. And I completely agree with Anne. I think she said it all, really. But I would say, you know, within Philips, we have the advantage of really looking at this globally, right? So we see what's happening in Europe, we see what's happening in Australia. And I think one of the questions is also not just, you know, what technology is out there, but why aren't we using it? So if you look at Denmark, right, they have home fetal non-stress test for every mom that needs it. These moms don't need to go in to get care. They can be monitored from home. Why don't we have that? I mean, we all know the reasons, right? But I think the technologies are there. So I think, you know, some of the areas are things like providing access to care by making it convenient for the mom, right? Meeting them where they're at. I think it's also helping moms and their community, their support network, confirm their gut, right? So whether it's during prenatal care, they think something's off, they need a community to help them confirm that they're right, that their gut is right. And the same thing is true, let's say, immediately postpartum, right? A lot of times you'll hear these really heart-wrenching stories about grandma being in the room right after the baby's born. something is off. Mom knows it, grandma knows it, they share it with the provider, but the message doesn't get through. And I think that is an area where, you know, we see a lot of early warning scores. So basically algorithms that look for specific early signs of conditions that are going to occur. So it could be hemorrhage, or it could be infection, or it could be a number of other things, right? Spotting those a little bit early and backing up what the mom or the grandma is seeing, but with something objective, may be a tool that can help. Now, I don't think that one is yet as proven, particularly when you have bias, but I think that there is potential there. And just one other point I think also is there's technology, and then there's also technology companies, right? And I think that technology companies, for example, large companies like Philips and others, do have another role to play in working with an ecosystem to solve these challenges. So I think it's also our responsibility to be involved, and Philips is, with March of Dimes or Momnibus or Connected Moms or whatever it is, to drive it forward. So those are some examples. I think they're really what Anne shared, but I really think the sky is the limit here. But of course, it's only one aspect, right? The provider at the end of the day is the one that's going to create that change, and for that they need reimbursement. So it's an ecosystem.
Absolutely. Thank you, Veronica. Dr. Sylvester, I would love to hear your perspective from Johnson & Johnson. There's a question that actually came in, and it is in regards to, you know, how can the use of technology and the role of remote care, telehealth, biosensors be used as a supplement rather than a complement to in-person clinical care? And how do physicians and those in healthcare settings use technology to their advantage without leaning on it too much? I'd love to hear your thoughts on this.
Yeah, no, thank you, Alexis. And I mean, Anne and Veronica stated it so well. I mean, technology indeed can play a central role in solving maternal health disparities if it's used appropriately, of course, just like anything else. Technologies can really offer different services that are targeted for populations at risk, especially in areas that are considered maternity deserts. I think I saw one of the questions related to maternity deserts, you know, in places where, you know, women don't have the availability of providers at her fingertips, or where she has to travel for hours to go to an appointment. So these mobile or telehealth interventions have the potential for supporting that remote clinical diagnosis, for improving the provider-patient communication, and that availability to users to offer on a continuous basis, you know, information that can minimize time and effort required for, you know, for visiting a provider, for example, and also having that opportunity to ease access to that updated healthcare data. To Veronica's point, that sometimes, I mean, this is in the context, what I was saying was in the context of somebody who's at home, but the importance also is, you know, is two: the woman who's at home, but also the woman who's giving birth at the hospital, who's having, you know, who just had that baby and who's having symptoms. How can you transform that data into insights that are going to be useful for providers? So one point I wanted to highlight, because you in that question, there was you know, some reference to how can providers not lean too much into it. And I think that's an important, very important point, because it's something that can seem very obvious, but it's very neglected also, is the development of new technologies. How do we bring the women's voice into that development of the technology? Because she is a central stakeholder, you know, for lack of a better term, in the process. You know, how, and you know, there have been research about that. There, in a recent article I read from researchers from Georgia, for example, that they were writing about how to promote mobile technologies for Black mothers. And researchers identified that the lack of inclusion of Black women mobile health interventions have led to a number of barriers, lack of interest, that they believe that, the research is not prioritizing minority groups, mistrust of privacy concerns. So overall, to Veronica's point, there is an ecosystem, and women are part of that ecosystem too, and providers obviously are part of that ecosystem too, payers as well. So innovations can save lives, but they can only be as successful as the recipients of the innovation allow it to be, meaning women and meaning healthcare providers and so on. So if there is no cooperation in breaking these barriers or silos between the research and the community, it's gonna be really hard for women of color to embrace innovations in full, and for providers also who are, serving communities of color to serve the women to the best way possible.
I love that. And I think that this is a really good point where Dr. Saul can weigh in, especially from the Mother-Baby Center and that perspective on being in the clinic with women and listening to women. I know that that's one thing that you shared in your introduction. So I would love to hear your thoughts.
Yeah, as I was listening, the thing that I just kept coming back to is what we're talking about is making sure that we have options for people in terms of how they can receive healthcare. There is no one way to do this. And I think that the option to have a remote prenatal care visit or the option to have remote antenatal testing would prevent, I have patients that drive an hour, 2.5 hours to come to my office for a 30-minute test. And I think that if we can make it easier for people to receive their care and meet them where they are, and make it easier for those care providers to actually interface with the technologies that we're using, much of what has been said, I don't think that any technology replaces human interaction and human contact, and I don't think that that's what anyone here is saying. And so I do think it has to be a complement to what we as physicians were trained to do, which was to interact with patients in person, examining our patients, all of those things. But as a busy mother, I think back to my second pregnancy, and I would have been labeled a non-compliant patient at certain points in my pregnancy, just because it's difficult to get to your appointments all of the time in those working hours of the day, and I think that to increase the way we can provide care and improve the way that access is granted to all of our patients, making it convenient and providing me the information that I need to know about my patient, because that's the part that can't be hard. That's the part that I can't have to search in 4 different places to find that information, I think is a win. And again, it's something that's long overdue, because I think we tend to get into it has to be this way or that way. And I think it can be always, but it needs to be customized to what that particular patient needs. And if we can focus our energies there, I think that we have a variety of ways that we can offer superb care to patients who ordinarily would not be able to access it for a variety of reasons.
Thank you, Dr. Saul. We're going to transition into our final topic, and that is going to be around innovative partnerships, the importance of innovative partnerships, and each panelist's individual call to action on this issue. What role, so here's the question, what role can or does innovative partnerships play in solving this pressing issue? And I say this because as we started this discussion today, we had that great fireside chat where it was a partnership between United Healthcare and also March of Dimes, which was dynamic and amazing, and I'm so excited to see where that goes. But I'd love to hear each and every one of our panelists' perspective on this, and we're going to start with Dr. Sylvester.
Thank you, Alexis. This is a topic dear to my heart. And throughout the conversation today, we have mentioned, in the fireside chat and even here during this panel, we have mentioned of the layered complexities of these issues surrounding maternal health disparities and the importance of having options for everyone. And the issues are multiple, and solving one does not mean that the entirety of the problem will be gone. So addressing the social determinants of health, as I stated above, is essential for maternal health to improve overall. And addressing these social determinants of health is not a thing of one group or one organization or one person. Addressing the root causes of structural racism, for example, requires fundamental social change. Addressing the challenges of providing safe spaces for women, nutrition, access to care, access to reproductive services, the ability for women of color to have employment opportunities also require commitment, and it requires common ground from multiple groups, including the private sector, government institutions, academic organizations, community groups, policymakers, and women too. So at Johnson & Johnson, I can provide the perspective of Johnson & Johnson as a company. We believe that addressing maternal health requires that type of collaboration and commitment. As an example, in 2018, J&J connected with multiple groups to found the Equitable Maternal Health Coalition, which is an alliance of maternal health stakeholders and partners working to reduce maternal morbidity and mortality at a national level through policy and advocacy actions and effective program implementation. This is at a national level. Then in 2019, we established a collaboration with the Center for Maternal Health Equity at Morehouse School of Medicine, and we established the Georgia Maternal Health Research for Action Steering Committee. And during this committee, the committee is composed by experts of different institutions, leading institutions in Georgia, who have the deep clinical public health, the behavioral and social expertise in these issues surrounding the reality of maternal health in the state of Georgia. They have very close ties with community organizations where women share their voices and where women feel heard. We have heard about, Black women in particular not feeling heard. The goal of the committee is to identify priorities that can be tackled with evidence-based local solutions. We initiated the program in December, for example, by establishing these local priorities to address local problems, because understanding the root causes of the problem in each community is essential for the problem to be addressed. To be truly addressed. We cannot say that the same thing that happens in Georgia, for example, is the same that's happening in the Bronx. Two different communities. So we're also fostering an environment where solutions come from within and not from the outside. In other words, really fostering, local innovation is needed to guarantee that the solutions are culturally appropriate and relevant. We're also promoting local collaboration. We know that each community has champions of change and experts who understand the local context. We as private sector, as industry, could serve as conveners of the various experts and leaders in the space to foster that environment of collaboration and to strengthen the linkages of communication between the various groups engaged in the different solutions. The other part of the story is that there have been many interventions that have been tried. It's not, I'm not here to say that there aren't people who have been working on this for a while. There are people who have been working here for a while. So proven interventions are key to ensure that these solutions are evidence-based, that they are scalable and replicable. At the same time, I mentioned that there are solutions that have been put in place or at least tried. The space is really underfunded. Oftentimes, some of these solutions are scaled without full assessment of their impact. So it's critical to measure the impact of these different ideas or solutions, interventions from a clinical point of view, but also from a policy and an implementation point of view, so that the long-term benefits can be easily translated into really guaranteed success. And the last thing I would say is that, one single solution is not the answer. The problem is complex. So an appropriate mix of interventions to reduce the burden of maternal morbidity and mortality is probably what we need. And that also means, you know, an approach that's integrated, that includes different members of the community, that includes different voices, where, you know, everybody pitches in about their different perspectives, so we can find something that's sustainable in the long run. And the last thing I'm gonna say, Alexis, you mentioned about our call to action. I think each one of you, if each one of us can do something about the problem, whether it's in your domain of expertise, whether you are engaged in working in maternal health, or whether you are a, you know, private individual, a private citizen, you know, standing up for women when they, you know, when they need, you know, lending a hand for the woman who cannot go to her appointment, trying to find resources for that woman in the postpartum period when she has postpartum depression. So I think that all of us in our individual way can do something about it. And if we put our efforts together, we can really, you know, try to, you know, solve the problem in a more meaningful way.
Thank you, Dr. Sylvester. I really appreciate the thoughtfulness around that answer. Veronica, we're going to transition into you, some thoughts here as well.
Yeah, I again completely agree. So that's funny how these things go, right? I would say a couple of things. One is the first way that I think, you know, ecosystems and going at this together solves the issue is raising awareness, right? You know, when Kamala Harris talks about this, when we talk about this, when the more that we talk about this, the greater the awareness is. And I think, you know, in a sense, that's also my call to action to the group, just to get straight to the point, is to continue talking about it, to continue raising awareness, and both for why we care, but also what the impact of it is from a quantitative perspective, right? What does it cost? Right? If we go back to the technology question, right? How much does it cost? A lot of these are Medicaid moms, right? To pay for their transportation to and from the hospital, to not identify these conditions early. It costs the system a lot. And I think one of the barriers that we'll also have to overcome to move things forward is working as an ecosystem to raise awareness for also the economic implications, right? Because we're not going to solve it until there's reimbursement, and we won't have reimbursement until everybody's aware just how much this also costs. So that's jumping ahead a little bit, but that's sort of my call to action, is also to talk about the quantitative side of things. But to get back to, you know, kind of why we need ecosystems to solve this, I think it is multifaceted. If we think again about that specific example, right, of the remote monitoring at home, that technology has been around since the 50s. You could do fetal monitoring in home in the 50s, right? We're a long time from the 50s or the 60s or even the 80s, right? So what happened? And I think what happened is, historically, we've been going at this separately. And recently, I would say in the last couple of years, you've really seen everybody coming together. So for example, you know, we as Philips collaborate a lot recently with legislators. So Maile, who was originally actually going to be on this panel from Philips, is extremely active, for example, in grassroots, in, you know, different March of Dimes blanket change initiative, or getting our own internal employees to send letters to change the legislation and the support that's in place already. But not just obviously legislation. I think it's also around working with payers, with providers, making sure we know what the real underlying causes are, and being able to pressure test what works to solve the issues. So from our perspective, I think as Philips, you know, it's one of our top priorities, right, is impacting lives, and what is a more worthy cause than this? But obviously we can't do it ourselves, right? Technology can't be done in a vacuum. So that's my perspective anyway on the need for the ecosystem.
Veronica, thank you for that. And we're going to transition into having Dr. Saul share her perspective. But one thing I wanted to highlight, as Medical Alley Association, you know, we're really dedicated, and as many can probably see in our membership, of the different sectors that make up the entire ecosystem, and the strong belief that if these sectors are able to work together, we can really transform healthcare. So that really kind of gets at what you're saying in regards to those partnerships. But Dr. Saul, I'd love to hear a little bit from you on this topic, and in particular to the role that these different sectors can play in, you know, continued working together for solving some of these challenges.
Sure. I think where I would start is with the call to action that dovetails into some of the work that we're doing that integrates some of this work. It's important that we personalize this work and that we put faces and stories and humans in front of us as we are trying to solve these problems, because I think in many ways we can have a lot of technological solutions to what we're talking about right now, and if we're not tying it to people and the people that we're serving and trying to care for, we might be having this conversation 10, 20 years from now. So I would encourage the curiosity around people and getting to know about and learn about people who are different from who you are, whoever you are, because I think that for me is at the root of all of this, is recognizing that everyone has a story. Everyone has a background. Everyone has a family or people who care about them, and it's important. It's important as a physician, and I say that talking about what we're doing right now, is that sometimes people become patients and they stop being people. And so the work that we're doing right now is getting into how do we personalize care in a different way. How do we personalize the prenatal, birth, and fourth trimester, the postpartum journey, so that we're recognizing who each person is that we're taking care of, what's important to them, who's important to them, and having significant conversations around care before we get into the hospital for birth, when labor is happening and it's more of an acute situation. And we're working with an IT company to tie that into our electronic medical record, so that we are having these conversations and intentionally seeking out very important information and preferences. So I'm Lisa, my husband is Mark, I have 2 other children. This is my religious, this is where we worship. This is how our faith may play into our birth experience. These are the traditions that are part of our family surrounding birth, etc., as well as the early warning signs that we talked about before related to blood pressure and sepsis, and that sort of education that needs to happen when things are calm, when things are in the office or over a screen in a telehealth visit, so that our patients, people who we know now it's unusual for the same doctor to take care of you during your pregnancy as who delivers you and postpartum. There needs to be a connection point. There needs to be a feeling of continuum and team, and that team is communicating about you, with you, so that we're not having people have to repeat themselves or answer the same questions 20 times during the course of their pregnancy. That doesn't build trust. That wouldn't make me feel very secure. And so that is where we're starting. And as a result of that, it has really encouraged our teams to open their minds about different cultures, learn about their own biases, learn about how to be anti-racist, not just not racist, and really starting to appreciate their role in the experience for all of the patients that we care for, but especially our patients of color, and how attitudes, comments, different things result in the microaggressions that our patients experience when they're in our care. And that's where we're starting. And so it is really at the bedside, and look forward to other ways that we can engage with our technological partners with how can we get MyFitnessPal for pregnancy? How can we get people to be more prepared for pregnancy, given that we know most pregnancies are not planned? So how do we start way upstream in the healthcare journey, so that by the time people are pregnant and building their families, we're starting at a good place and starting at a good baseline, so that the conversations around pregnancy and the pregnancy care can take off from there. Just a few things that that are on my wish list if I had to make one.
Well, thank you for sharing that. And I think that this is a really great time to transition into Anne, who's going to close us out here to talk a bit more about the partnerships and the value that it brings to technology and innovation. So Anne, can you please share your thoughts here?
Sure. And this is really hard to go at the end after listening to these amazing people, but just for me, it really does go back to the ecosystem and the partnerships, because it's not going to happen with just one group. It has to be all of us and working together, me on the technology side and really trying to create technologies that can really leapfrog where we are right now. It's working with all the providers and the payers, the government side and the commercial side, who has that financial risk and really wants to see better outcomes for the patients. And it doesn't matter where they are, if they're rural areas, urban areas, and utilize technology for the technology itself in capturing data, but then also using technology for education. We talked about education, and there's so many ways that we can use technology to better educate women before their pregnancy, during their pregnancy, and postpartum care. I mean, it's interesting when you talk to some of these women that have had pretty significant postpartum care issues and how they've kind of figured out what was going on with them. And it's reading a story about Serena Williams in Vogue magazine, realizing, oh my gosh, I think I'm having a pulmonary embolism. So we've got to do a much better job on the educating side too. And I believe that technology can be a piece of that. I do. I think we can capture better data. We can turn it into better information, and it's really got to be good information. Otherwise, it's not going to get used, and it can be overwhelming for the providers that really have to provide the care for these patients. And it needs to be done affordably. Reimbursement is so significant for everyone that's developing technology and bringing technologies to the market. Just like Veronica was saying, it's very critical. And but we still have to really watch how we develop the technology. What is the cost of the technology? And then with that technology, make sure that we're providing data in a timely manner just to improve outcomes and decrease the cost of care. And one of the things that I do look at this quite frequently, because I've got a fairly significant background in cardiology, and I look at chronic disease management. And what has happened in chronic disease management over the past 15 to 20 years, and you look at how things have advanced in cardiology, and you look at the research that's been done and the investment in technology, and then you come over and you look at what we're trying to do with care for women and overall. And when we look at this segment, it's prior to pregnancy, just like we were saying, prior to pregnancy, it's during that prenatal care period, it's labor and delivery, it's postpartum care. We've got to do a better job with research, and we have to do a better job with investment in this area so that we can get the new technologies that are going to make things a little bit easier for the care providers. So I think we've got a long way to go, but I am positive that it's happening. It really is happening. And from my perspective, I'm, just starting to see more dollars fly into femtech and women's healthcare, which is phenomenal. But I'm optimistic for the future. It just can't happen fast enough.
Well, I agree. I think all of us could just have this conversation for even longer. So I am sad that we're going to have to wrap, but I am also very thankful for all of you for this thought-provoking conversation. And I think at the end of the day, the solutions to this are complex and multifaceted. And if one thing is apparent, innovation through medical technology and partnerships is unbelievably important, but is also one of many critical pathways to equity on this issue. So once again, thank you all for our panelists for joining us today. And I just want to remind our viewers that Medical Alley Association is committed to using our platform to elevate crucial topics like this one and creating opportunities for leaders to come together to break down these silos and have these important conversations. So I want to encourage all of our viewers to continue to join us for more webinars and check out more information on Medical Alley Association at medicalalley.org. So thank you all. I hope you all have a wonderful evening, and we hope to see you next time.